restored or discolored due to death of the pulp. Formation of inflammatory exudate in the periodontal ligament causes the tooth to be extruded by a minute amount and the bite to fall more heavily on it. The tooth is at first uncomfortable, then increasingly tender, even to mere touch. Hot or cold substances do not cause pain in the tooth unless some viable pulp remains, as it may in a multi-rooted tooth. Unlike pulpitis, apical periodontitis is accurately localized by pain fibers and proprioception in the periodontal ligament, and the patient will usually point correctly to the causative tooth. Radiographs give little information because bony changes take time to develop. Immediately around the apex, the lamina dura may appear slightly hazy and the periodontal space may be slightly widened. When acute periodontitis is due to an acute exacerbation in a periapical granuloma, see later in this chapter, the granuloma can be seen as an area of radiolucency at the apex. While apical periodontitis remains a localized apical inflammatory change, no facial edema or alveolar tenderness or other reactions develop. Their onset indicates progression to apical infection. Pathology and sequelae. Acute apical periodontitis is a typical acute inflammatory reaction with engorged blood vessels and packing of the tissue with neutrophils, Fig 5.16. These changes are initially localized to the immediate vicinity of the apex. Fig 5.16. Acute apical periodontitis. In this early acute lesion, inflammatory cells, mainly neutrophil polymorphonuclear leukocytes, are seen clustered around the apex of a non-vital tooth. The inflammatory cells are spreading into bone, and there has only been time for a small amount of bone resorption to develop. This would be seen radiographically only as slight fuzziness of the apical lamina dura. At this stage, periapical periodontitis is usually treated, triggered by the severe toothache. Extraction of the causative tooth or extirpation of the pulp and root filling eliminates the source of infection and drains the exudate. These are the simplest and most effective treatments. Antibiotics should not be given for simple acute periodontitis if immediate dental treatment is available. If untreated, there are two possible outcomes depending on the balance between the virulence of the bacteria and the host defenses. The usual outcome is that a chronic periapical granuloma forms, later in this chapter. However, if the bacterial load is high, species are virulent or host response is inadequate, the infection will progress to an apical, or dentoalveolar, abscess, box 5.4. BOX 5.4 PO SSIBLE CO MPLICATONSOF Acute apic ALPERIO dontitis apical abscess formation regional lymphadenopathy spreading infection acute apical, dentoalveolar, abscess. The bacterial flora in the pulp chamber includes potentially virulent species, mostly anaerobic, but can only induce an abscess if sufficient bacteria pass through the apex. The bacteria trigger acute inflammation, pus starts to form and pain becomes intense and throbbing in character. At this stage, the gingiva over the root is red and tender, but there is no swelling while inflammation is confined within the bone. Like apical periodontitis, the pain of an apical abscess is accurately localized by the patient because periodontal ligament pain and proprioceptors are triggered. An established abscess will usually either drain through a sinus and become chronic or, much more rarely, progress to osteomyelitis or cellulitis. Usually, pus and exudate will burrow a sinus tract to the closest alveolar mucosa, Fig 5.17, unless an adjacent pocket or the nearby skin provide a path of less resistance. Once infection escapes into the medullary cavity of the bone, edema may develop in the soft tissues of the face, Fig 5.18. Fig 5.17 Alveolar abscess with a sinus from the premolar apex to the overlying alveolar mucosa, where a small bead of pus is visible through the distended mucosa, a pointing sinus. Once this bursts and the sinus drains, the opening will become much less obvious. Fig 5.18 Edema due to acute apical periodontitis. An acute periapical infection of a canine has perforated the buccal plate of bone causing edema of the face. This quickly subsided when the infection was treated. Escape of pus to the skin is not common, but a classical presentation is the tracking of a sinus onto the skin near the chin as a result of a traumatically devitalized lower incisor, Figs 5.19 to 5.20. The regional lymph nodes may be enlarged and tender, but systemic symptoms are usually slight or absent. Fig 5.19, a persistent skin sinus from a lower incisor rendered non-vital by a blow some time previously. This young woman was seen and treated unsuccessfully for 2 years by her doctor, surgeons, and dermatologists before anyone looked at her teeth. Fig 5.20, non-vital incisor teeth, in this case as a result of trauma. Hemorrhage and products of autolysis of the pulp discolor the dentine and darken the teeth. Escape of pus takes a few days after the onset of pain. This relieves the pressure and pain quickly abates. If the exudate cannot escape, it may distend the soft tissues elsewhere to form a soft tissue abscess or cellulitis as described in Chapter 9. Apical abscesses are polymicrobial infections and numerous pathogenic species are present, including Bacteroides sp, Prevotella sp, Spirochetes, Porphyromitis sp, Streptococcus sp, Fusobacterium sp, and Actinomyces sp. No particular species can be identified that are particularly responsible for symptoms or progression. Despite the mixed nature of the infection, penicillins remain the most effective antibiotics, with metronidazole reserved for patients allergic to penicillin. However, an apical abscess cannot be treated by antibiotics alone. The causative tooth or its pulp must be dealt with because bacteria in the pulp chamber are inaccessible to the drug. Symptoms and antibiotic treatment. PMID 1645700 U.S. Guideline Antibiotic Treatment. PMID 316681770 Fatal Outcome. PMID 810-5884 Chronic apical periodontitis and periapical granuloma Summary Chart 5.1, P79 Most necrotic pulps do not progress to abscess, but form a chronic periapical granuloma, a focus of chronic inflammation at the root apex. Most develop without symptoms, but they can also arise after acute apical periodontitis, particularly when it has been inadequately treated and resolved incompletely. A periapical granuloma is caused by frustrated healing. The granuloma itself is sterile in almost all cases, but bacteria and irritants from necrotic tissue remain in the pulp chamber, inaccessible to the host response. Small numbers of bacteria may occasionally pass through the apex but are quickly eliminated by the host defenses. However, the continual trickle of irritants from the persistent reservoir of infection in the root canal into the periapical region prevents healing. Clinical features: the tooth is non-vital and may be slightly tender to percussion, but otherwise, symptoms may be minimal and are often completely absent. Many periapical granulomas are first recognized as chance findings in a radiograph, Fig 5.21. The granuloma forms a periapical area of radiolucency a few millimeters in diameter with loss of continuity of the lamina dura around the apex. In long-standing lesions there may be hypersmentosis on the adjacent root or slight superficial root resorption. The margins of the radiolucency may appear fuzzy when inflammation or infection are active, but are usually well defined and appear sharper in larger lesions. Good demarcation and size alone are not evidence of radicular cyst formation, ch10. Fig 5.21 Chronic apical abscess. Periapical bone resorption has developed as a result of inflammation. The area of radiolucency corresponds with the histological changes seen in Figure 5.22. Pathology: a periapical granuloma is a typical focus of chronic inflammation characterized by lymphocytes, macrophages, and plasma cells in granulation tissue. It is important to recognize that a periapical granuloma does not contain true granulomas histologically. The term granuloma is a historic description for granulation tissue, in the same way that the word is used in pyogenic granuloma. Inflammation is densest in the center, close to the root apex, and there is an uninflamed layer of fibrous tissue around the periphery, separating the inflamed tissue from the bone. Osteoclasts resorb the bone peripherally to make space for the granuloma. There may be a central cavity with a few neutrophils, but no pus and no infection. Figs 5.22 and 5.23. Fig 5.22 Chronic periapical abscess. At the apex of the non-vital tooth, top center of picture, is an abscess cavity surrounded by a thick fibrous wall densely infiltrated by inflammatory cells, predominantly neutrophils. Periapical bone has been resorbed and the trabeculae reorientated around the mass. Fig 5.23 High-power view of an apical granuloma showing neutrophils, lymphocytes, and plasma cells in loose edematous fibrous tissue. Inflammation may trigger epithelial rests of Malassez in the adjacent periodontal ligament to proliferate, Fig 5.24, and this is the mechanism by which radicular cysts occasionally develop, ch. 10. Fig 5.24 Epithelial proliferation in an apical granuloma. Inflammation induces proliferation of odontogenic epithelium in rests of Malassez in the periodontal ligament. This change may lead to cyst formation, ch. 10. Treatment and sequelae. A periapical granuloma will resolve if the causative necrotic pulp is removed, so extraction or endodontic treatment are the two options. Persistence after root canal treatment indicates treatment failure and retreatment or apicectomy may be required, Fig 5.25. Fig 5.25 Low power to show the effects of successful apicectomy. The chronic inflammatory reaction has entirely cleared. New bone has formed to replace the excised apex with a new continuous periodontal ligament and lamina dura. The root-filling material in the canal has been lost in preparing the section because it is too hard to cut. A few fragments of the reverse root-filling material left in the surgical cavity have been incorporated into the medullary bone, seen as dark specks above the end of the sectioned root. These have been incorporated into the tissue without inducing inflammation. Without treatment, the most likely outcome for a periapical granuloma is that it will persist largely unchanged. There may be acute inflammatory exacerbations with symptoms from time to time, often insufficient to cause a patient to seek treatment. The risk of leaving an untreated periapical granuloma is that it will develop into an acute periapical abscess. This is unpredictable, and granulomas that have been asymptomatic for decades may suddenly develop into an abscess. During any of these acute abscess exacerbations, a sinus may form. Sinus formation reduces pressure and usually allows the infection to persist as a chronic low-grade infection. Sinuses will normally heal when the cause is treated and do not require excision. Otherwise, they may drain intermittently and heal after each acute exacerbation. Successful treatment is followed by resolution of inflammation, reforming of the lamina dura and periodontal ligament and bone around the apex. In rare cases, there is healing only by fibrosis. This is more frequent in the maxilla than mandible and when inflammation has resorbed the overlying cortical bone. Fibrous healing to produce an apical scar is seen radiographically and appears similar to a persisting granuloma, causing a potential problem in diagnosis and when assessing the success of root canal therapy. Persistence of a periapical granuloma following root treatment is very occasionally due to the presence of bacteria within the granuloma. Although most periapical granulomas are sterile, the bacteria being limited to the pulp, in a very small number of cases actinomyces or other organisms can form a biofilm on the outer root surface or free-floating colonies in the center of the granuloma. This must be distinguished from an acute periapical abscess. The organisms in extraradicular infection are of low virulence and remain localized, cause persistent low-grade inflammation but do not form much pus or cause a spreading infection. Extraradicular infection usually has to be eliminated by apicectomy or extraction. Failure to heal after treatment requires investigation. Reasons include inadequate root canal treatment, extraradicular infection, and an apical foreign body reaction to food components forced through the apex when the coronal pulp chamber is exposed by caries or left open to drain to too long, pulse granuloma. Occasionally what appears clinically as a periapical granuloma is a radicular or other cyst, ch. 10, cementoosseous dysplasia, ch. 11, odontogenic tumor, ch. 11, or other completely unexpected disease. Causes of treatment failure are summarized in Box 5.5 and Summary Chart 5.1. BOX 5.5 REASONSFOR